Thank you, Paul. Welcome. I want to first acknowledge Paul and all his efforts to put this together, and appreciate everyone's willingness to come and tonight to be party to it. Tonight's symposium is on the rotator cuff. It's going to be certainly one of the most central areas as to why rehabilitative therapy, physical therapy, is essential in the shoulder. It's essential for all aspects, but mainly because all aspects of shoulders involve rotator cuff to some extent. It can be instability, total shoulder replacement, fracture. It all comes down to the cuff and cuff functioning. So this is about cuff and cuff functioning primarily as an anatomic issue. All right. So first off, and a couple of these slides are a little bit different than what you have there. The way I'm going to put this together is, Paul said I'm going to talk about pathanatomy of rotator cuff tears and surgical approaches, and but he failed to mention that I also tend to wax poetic about the shoulder a little bit, because I think the shoulder is pretty interesting. It's unique, and for those of you who have had a chance to do much physical therapy with it, I think you'll hopefully try to connect some dots tonight as to why it can be challenging and why that which you do is so centrally important. First, the shoulder is unique in the human body, and it has a bilaminar construct of muscles, two layers of muscles. The outer muscles, the muscles that we see, the deltoid, trapezius, pectoralis, the power muscles, the drivers, that which generates force and production of effort. But then there's an inner layer of muscles. That's the rotator cuff. The shoulder is designed, it has more motion than any other joint in the body for the very purpose of taking advantage of our prehensile thumb. We need to position the hand in space. The capacity of the shoulder joint, if you take the ligaments in the shoulder, they are naturally lax, which means if you would blow the shoulder up like a balloon with water in it, the shoulder has the volume naturally to contain two humeral heads. So that's why the shoulder has so much range of motion potential. So the ligaments only get tight and taut at end range of motion. So controlling all this central range of motion is largely the function of the cuff. Now there's some surface issues, and the glenolateral construct is important because there's some concavity there, but the cuff is centrally important. And as you all know before review, so anteriorly here be the subscapularis, which covers the front of the shoulder. The biceps tendon is missing, which is an important part of the shoulder, not so much in terms of a head depressor or function, but it's more kinesthetic. I think the biceps is more of an elbow muscle. The important thing in the biceps and the shoulder, we'll get later, is it is a wicked pain generator, and it generates a pain pattern that's just like cuff. So many times these are admixed, or they can be confused with one another. Then the posterior shoulder, the infraspinatus and teres minor, and together they create a hood. I think that whoever coined the rotator cuff anatomically would be better called a rotator hood, because it is a collective of tendons. If I were to show you, if you were to look at the time of surgery and you would see a confluent white tendon strip, and say, which one is supraspinatus? Well, supraspinatus sort of goes from here to here, and infraspinatus goes from here to here. So they are in continuity. The shoulder functions with ball and socket kinematics, just like the hip. So, which means if you put a dot in the middle of the humeral head and move your shoulder through a range of motion, that dot should not move more than about 1 millimeter. So the shoulder natural movement is all rotational. It's not translational. Now, there's some coupled motions at end range, 1 to 2 millimeters maybe. But if the shoulder moves abnormally, it's translational in nature. If it moves abnormally anteriorly, it's anterior instability, subluxation. If it moves too abnormal posteriorly, it's posterior instability. If it tries to move too abnormal superiorly, well, you say, well, it can't. Well, it can try. I mean, the acromion's going to block it, and the supraspinatus is there, but that is impingement. So when the humeral head isn't contained well in the glenolateral socket and it wants to move superiorly, that's what is the essence of mechanical impingement. The rotator cuff, these are from some cadaveric studies, and here's a specimen in which the humeral head, that's the biceps tendon, and this would be the subscapularis muscle. And these are all separated out for the picture, but supraspinatus, infraspinatus, teres minor. But there's a way to calculate potential force by cross-sectional area and weights and all that. This has been done in a number of cadaveric studies. That the force generation of the rotator cuff is balanced anterior to posterior across the biceps. So which means the subscapular, in terms of ability to generate force, which means larger, it means size. The subscapularis equals supraspinatus, infraspinatus, teres minor combined. So we start talking about force couples in the shoulder, because the way the rotator cuff works is that the anterior cuff, posterior cuff work together, result in vector compression. That's stability. So we talk about, so sometimes when you're dealing as a therapist with weakness and the rotator cuff needs to be strengthened, it may be that you're dealing with imbalance. Because typically the internal rotators are about 3-2 stronger than external rotators, which means the internal rotators of the shoulder, subscapularis, pectoralis, and latissimus, powerful internal rotators. They can easily overwhelm the external rotators, which is really cuff, posterior deltoid a little bit. So a lot of time what you're dealing with is imbalance. But this is the biomechanical, biological rationale when you hear of balanced force couples in the shoulder, because it is balanced across the biceps. So you have these balanced force couples, this cuff, this effort to try to keep the humeral head centered in the glenolateral socket, and then the shoulder functions the way God intended, the way our evolution is intended. And the purpose of the shoulder is to take advantage of one of the most important evolutionary advantages, probably second to the big brain. I mean, the Homo sapiens, the big brain and the prefrontal lobes and all that are obviously the most important. But functionally, it's the prehensile thumb. It really separates us from all else. And ability to use weapons and maybe I should use that one first. But building and throwing and things like that, functional activities. So the shoulder is designed to position this hand in space. So you have all this structure for the shoulder, and the problem is when it raises the hand in space, it can potentially pinch. So here's the humerus here, and this would be like the acromion over the top. And when this thing rotates up, it shoves the supraspinatus, maybe biceps area, under the greater tuberosity, which is a little bit prominent, into the acromion, or has the potential to. That's what impingement is. So the shoulder is designed to be an impinging machine. And much of why so many of the shoulder pathologies have cuff involved is that anything in the shoulder that distorts its motion, strength, or anything will bring the rotator cuff into play. So, someone who has some instability will also have some bursitis and impingement. Why? Because the cuff is dysfunctional a little bit. Does that mean the cuff needs to be treated? Well, you can treat the cuff, and you can try, cinema physical therapy, rehab, strengthening, and maybe you can control the instability. But the cuff dysfunction is the secondary phenomenon. Just like frozen shoulder. The central problem is a stiffness in the shoulder. Yeah, the cuff's painful, and yeah, it's sore, and yeah, they have some weakness. But if you focus strengthening and leave that motion unaddressed, they may get some better, but they're not going to be solved. So the function of the rotator cuff is to stabilize the humeral head in the glenolateral socket. It's not really to initiate anything. It's not really to be a major force generator. Certainly rotational stuff is helpful as well, but it's mainly a force generator. And the problem is, you see in the subsequent slide, so the arm is like here, down at the side. Here's the humeral head at the side, and there's the deltoid, and there's the cuff. And so the cuff's going to work. The cuff's going to fire to create a stable glenolateral socket, a stable fulcrum, and then the deltoid is the one that raises the arm in space. But I mean, think about it for a moment. Look at the vector. The initial vector, when the arm's down here of the deltoid firing, is if you don't have a stable pivot, that head goes up. The deltoid is pulling the head up unless the pivot is stable. Now, normally you see the subacromial space. Well, it's not much of a space. I mean, there's a membrane in there called a bursa. So the way the shoulder anatomically is designed, it's like the piston engine in a car. It is fine tolerance, which means normally the rotator cuff and the acromion kind of barely touch. They glide past one another. So how much space is available? Not much. 3 millimeters. And that's why a lot of people, if you get a little bit of distortion in the bursa, a little bit of thickness, they have such audible noise, but it doesn't bother them. And if it doesn't bother them, I say, well, consider yourself fortunate that that doesn't bother you. But some people just have noisy shoulders. But that's why, because the bursa, if it gets a little bit bumpy, it can cause noise. Now, if the noise doesn't hurt, then the patients are fortunate. It's curious why it wouldn't hurt, because you know it's rough, and you know it could hurt. And usually when patients say it doesn't hurt, I don't try to over-explain the fact that it could hurt, because I'm concerned that I might sort of put a thought in their head that they're saying, well, now that you mentioned it, it is a little bit painful. So the extrinsic mechanisms of tendon injury, and we'll get later in the coracoacromial arch and all that, but you have this basic mechanism of the rotator cuff stabilizing the humeral head, the deltoid wanting to pull it up, and then as you'll see later, as we get older, everything it pulls up into gets sharp and prickly as we get older. Bone spurs form. So when I think of category of rotator cuff tears, and so what we're talking about today is just rotator cuff tears. I mean, you can pick volumes. We can just, what I've just talked about in terms of the pathophysiology of cuff dysfunction and pain we could talk all night about it. But we're going to talk specifically about tears. Now, when I think of tears in sort of two categories. So we've talked about the anatomy and how the rotator cuff functions. But I think of tears in terms of, was the tendon previously normal and then it ruptured? Or was the tendon previously not normal and it ruptured or tore? Now, if the tendon was previously normal, something big has to happen to that shoulder. Because typically, normal tendons generally don't rupture. Not because they can't, it's because they're not the weakest link in a chain. If you have a shoulder that has a normal tendon and some perturbation is applied to it, something else is going to tear. So, the classic example, and I think it's a good example in the shoulder to understand age-related change, is someone falls and has an abduction external rotation injury mechanism. Okay? The shoulder is going to want to try to come out of joint. In a 20-year-old, what's the weak link? The weak link in the shoulder in a 20-year-old is the capsule labrum. It's not that it's weak, it's just that the bone is hard and the tendons are great. So that mechanism, if something's going to distort at a 20-year-old, largely it's classic instability, labrum and capsule ligaments. You take about a 50-year-old, okay, and the same injury mechanism. Now, the labrum and capsule could tear, but more commonly, the rotator cuff tears. Not because the labrum and capsule is suddenly not as strong at age 50. It's because by age of 50, the tendon isn't quite as strong. So it's basically, a chain tears at its weakest link. So by middle age, the tendons become more of a weak link. Now, that being said, if I have a 55-year-old patient who dislocates their shoulder and they tear their ligaments and their labrum, what I tell them is, one, it's statistically uncommon, and you've just torn your shoulder in a pattern of a 20-year-old. What does that mean? That means they got great tendons. That's what it means. And usually what that means is genetically it's a gift, and they're healthy. They're healthy. Now you take a 75-year-old, same injury mechanism. The cuff may tear, but more likely the bone breaks. Not that the cuff is any stronger at age 75 than 50. It's not. It's just that there's a precipitous decline of bone quality in the proximal humerus as you get older. So a lot of it's just a weak link in the chain. So it takes quite a bit to tear these tendons. And usually it's some sort of a traumatic dislocation. But usually operative treatment is needed, and that's not really what we're going to talk about too much tonight, because the more interesting topic, this might be 2%. The more interesting topic is to talk about the 98%. Here's the 98%. Tendon tear in a previously abnormal tendon, meaning it's degenerative. It can be degenerative from, and it can then tear with macrotrauma, meaning they could dislocate or fall on an outstretched arm or some major event. It can tear with microtrauma, consistent repetitive injurious stress, a mail handler, something with repetitive overhead activity, something like that. Or it can just tear. It can melt apart. The biology fails. And that's something more like, one of my 70-year-old patients who's been symptomatic and painful for 3 or 4 months, no history of trauma, not very active, thinking they have some bursitis, and I examined and said, my God, you got a rotator cuff tear. They have no idea when it happened and when it occurred, and that's more of an insidious, progressive, degenerative biologic failure. With the extrinsic component, it's all about impingement. I'm not sure how this projects, but here's an example of the rotator cuff here. The acromion is here. This is the back of the shoulder. The acromion's been cut out, but it shows the this would be more of the teres minor, teres minor, infraspinatus, supraspinatus up here, but it shows everything is in close apposition in here. There's no room of tolerance at all, and so you start creating some bone spurs or some partial tendon tears, or the bursa gets thickened. There's no room for anything like that. And when you do, you have mechanical impingement, extrinsic impingement. And then it's like grit. Once it gets in there, it can cause problems. Like some people, raise their arm up and it hurts and it grinds. Well, that grinding is the problem. Things are coarsely rubbing against one another. The intrinsic is the biologic. It's vascular. It's age-related. It's degenerative. The shoulder is not unique, but it's one of the archetypes in the human body in a study of planned senescent change, age-related change. The most common and obvious aspect would be your hair growing gray. As we all get older, at some point, you're going to get some gray hairs. What does that mean? It just means you're getting older. Some people get a lot, some people get a little, but everyone gets some. The shoulder, these tendons deteriorate as we get older as a consequence of biology. It just happens. Then you add that with some bone spurring, and that with some applied weakness as they get older if they haven't stayed in as much physical condition, and it's a recipe. It's fertile ground for cuff dysfunction and maybe tears. I'm going to talk to you about senescent change for a moment because I think it's useful for you to understand it. Mainly, one, that you understand it, and two, that you can apply it to patients, because especially if many of you deal with patients, more senior patients, 55 and older, degenerative, especially 60s and 70 patients, they're going to have a lot of questions about spurs and all that. Senescent change in the body is a normal phenomenon of aging. It doesn't mean it has to hurt. And there are several things in the shoulder that are going predictable senescent change. First, the rotator cuff. Now, one thing I sort of have glossed over, but we talk about rotator cuff tears, and I keep saying tendon tears. The rotator cuff is a hood, and the subscapularis is in the front, supraspinatus sort of top, infraspinatus sort of posterior superior, and teres minor posteriorly. The shoulder in a degenerative always tears in the same pattern. It starts with the anterior. All degenerative tears in the shoulder start at the biceps aperture. So the supraspinatus tears from anterior to posterior. There are a few things that are predictable. That's predictable. So it tears from the biceps aperture posterior. So if it's a 2 centimeter tear, that means the 2 centimeters behind the biceps is torn. If it's a 4 centimeter tear, the 4 centimeters behind the biceps is torn. Now, there is some talk about, well, you can get isolated infraspinatus tears and all that. I'm not so sure. I mean, anything's possible, but that occurs very rarely. So the problem is, so it's the superior tendon, the supraspinatus. And if the supraspinatus tendon tear gets bad enough, the infraspinatus starts to peel off too. It's like getting a big hole in your shirt, and eventually it keeps tearing. But it doesn't extend anteriorly. The subscapularis tendon does not really exhibit degenerative change. You can have trauma to it. So degenerative change is superior tendons to back. So the supraspinatus, so when I say rotator cuff tear, I should be saying in a forum like this, an educational forum, supraspinatus. But I'm lazy about it, and I call it rotator cuff. But we're talking about supraspinatus. Most tendons in the body might get weak, but they don't structurally change. The tendons in the shoulder tend to get fatty degeneration, which means the tenocytes change the matrix. The matrix changes in the shoulder of the tendon. It literally changes. Why? It's just the way it is. It's just planned senescent change. Here's an extreme example, which makes for a nice slide, is the supraspinatus tendon that I had to remove, but it's fatty. Historically, they said it was mucinous change. It's really fat. And the muscles in the shoulder, when tendons tear in the shoulder and they go untreated, the muscles atrophy. Well, they all atrophy. You can have a quadriceps tendon tear, and you can get quadriceps atrophy. Achilles tear. Gastrocnemius atrophy. But those muscles don't change into fat. Rotator cuff changes into fat. And that's a bad deal. That's irreversible. That's bad. I mean, if I have someone who's got a rotator cuff tear, and maybe it's fixable, or maybe I got some ideas on how to fix it, and there's significant fatty degeneration, it's a waste of surgical time. To think you're going to, because you are attempting to reattach a tendon, that muscle doesn't work. And what's the point? So MRI is very helpful for that. We're not going to talk about much tonight, although if you have some questions later, we can talk about MRIs. In the shoulder, I don't know how these project, but here's the humeral head. The greater tuberosity starts getting all these little bumps and spurs here. The AC joint becomes radiographically arthritic. A lot of people, and if you've treated patients over 60, a lot of people come in and they'll have these little points and knobs over their AC joints. And if you had an X-ray, you say, you got some AC arthritis. They do. And does it hurt? Not very commonly. And if anything, if the AC joint is a problem, it's because whatever superior osteophyte projection you see coming up, which they can feel, there's usually an analogous one going down. The ones that go down are a problem because they impinge on the rotator cuff, the supraspinatus. But the AC joint becomes arthritic. And someone says, well, yeah, my AC joint's arthritic, and what does that mean? I said, well, it means you're not 20 anymore. Now, but it also means it's not biologically normal. It's not normal. I mean, it's not the way it was when you were 20. So all of a sudden, you have some age-related change, and you go out and do an activity, the AC joint might not be as tolerant of that activity. Maybe. But just because the AC joint's arthritic doesn't mean it's a bad thing. Bone spurs. Now, so everyone talks about bone spurs in the shoulder. So the acromion develops a hook on it as we get older. Now, this was a study done looking at young athletes, or college-age athletes. And so a acromion, so the bone on top of the supraspinatus, on top, the bony hood of the shoulder, if it's flat, it's generally called a type 1. And if it's really hooked, it's called a 3. And if it's not 1 or 3, it's a 2. It means 2 is kind of curved, somewhere in the middle. Young people generally don't have hooked acromions, 1%. As we get older, the bone forms in the coracoacromial ligament as like an enthesiophyte, which means bone forms as we get older, and the result is that a previously flat or curved acromial morphology is now hooked. And once it's hooked, it could be a problem. It might not. But you can imagine now, you're raising the arm up in space, the rotator cuff, you have something much more prompt to hit against. So that could be a problem. If the rotator cuff doesn't function properly, then this vector of the deltoid is going to drive that humeral head up. Now, this is an extreme example, but essentially that's what happens. And if it drives it up into a flat acromion, maybe it's not so bad. If it drives it up into a hooked acromion, that's not so good. So again, the compressive effect is not only rotator cuff strength, but balance across the biceps. Balance. Coacromial arch alterations can impact what we talked about, especially spurs. The other challenge, and this is a little aside if we're talking about before I get into surgery, but there's a myriad of shoulder girdle symptoms that are seen because the rotator cuff is the central functional element in the human shoulder, which means you're going to see cuff symptoms in nearly every human condition imaginable that affects the shoulder, whatever it is. And somehow, me as a physician, you as a therapist, have to discern, are the cuff symptoms real? Yes. Do they hurt? Yes. Because many times why they have so much pain is the subacromial bursitis gets heated and angry, and they hurt at night. And usually night pain is what drives a lot of people to surgery anyway, to seek relief of it. But what it comes down to is that your rehab effort most appropriately is addressing the rotator cuff. But is the rotator cuff primarily involved, or is it secondarily involved? Either way, you got to address it. But part of it to discern is that, how does it play in the patient's symptoms? And sometimes it's not so easy to figure out, at least for me. So there's numerous pathologies, other tendon pathologies. There can be chronicity, there can be posture, there can be scapula. We don't have time to go into all that. But just because someone has rotator cuff symptoms doesn't mean their primary problem is rotator cuff. And how they interpret their symptoms. If everybody came in saying, well, where's, so the classic, something I can see from down the hall, my shoulder hurts when I reach or work overhead. So, well, where does it hurt? It usually hurts right here. Sometimes it goes down to here. When I'm very active, it hurts at night. It's like, that's cuff. I'll go through the motions and try to, be sure it's not anything else. But that's classic. But what happens when they come in and they have a lot of anterior and posterior myofascial pain, and it's sort of all over, and they get this radiating pain down their arm, and it goes into their hand, maybe sometimes, or the back of the hand, not the palm, or all sorts of stuff. Or they swear sometimes their hand looks blue to them. It's complicated. Especially it involves complexity, their ability to deal with their pain, and the chronicity of it, and how they interpret it. And it's just an awareness that someone may have a myriad of complex shoulder issues, and at the core of it, they got a rotator cuff problem that is creating this incredible dense overlay of symptoms that if you can just sort through it, you understand how to treat it. Generally, complex symptoms reflect chronicity. I start with impingement syndrome and radiating arm symptoms, superior shoulder pain, sometimes neck pain, scapula pain dysfunction, hand symptoms, frozen shoulder. There's a myriad of things. And then they may have a whole bunch of these. Radiating pain down their arm, stiffness, neck pain, pain at night, all sorts of numbness issues, who knows? And yet the core problem has been a neglected rotator cuff tear or a rotator cuff problem. And from your perspective, from my challenge and your challenge as well, is if you can sort through that, you can one, give the patient some reassurance that this is not necessarily nerve damage. But I mean, I can't be 100% sure, but you can give some reassurance and say we start treating your core problem and then seeing how things unfold. Surgical treatment is best thought in terms of treat the shoulder like a mechanical part. So when things are prominent, they need to be smoothed. When things are thick, they need to be thinned. When things are torn, they need to be put back together. And when things are too tight, they need to be lengthened. That explains surgery of the shoulder for rotator cuff. It sounds simple, but it's not rocket science. It's just the shoulder. So the techniques, acromioplasty, any rotator cuff tendon surgery, be it whatever it is a supraspinatus and infraspinatus. You need to get the acromion flat. Give the cuff more space to work in. The tendons, if it's a partial tear and I'm debriding it, if there's a flap, if there's a flap, it's sticking up. It might be sticking up 3 or 4 millimeters. Well, there's no room for a 3 or 4 millimeter flap. You smooth it. The distal clavicle, removing osteophytes. Bursectomy, lice adhesions. You've got to get that bursa cleaned out. Now, bursa form anywhere in the human body where there's motion between two tissue planes. So I say, when I'm going to take out your bursa, I say, I'm going to take out as much bursa as I can humanly remove. If I can get 100%, you probably can't, but if I can get close to it, I will. So what about it? I said, it's going to reform. Because it reforms through motion and therapy. Pretty quick. The bursa forms as fast as skin heals. But the bursa should be a monolayer, 2 playing cards, thin, smooth, Teflon, not this thick, wad, gristled, fibrotic mat. But that's what subacromial cortisone injections can do. It kind of melt the bursa down some. The biceps tendon can be really involved in this as a pain generator. I'm telling you, there are a lot of times when I'm in surgery, it's a rotator cuff tendon tear, pretty straightforward, and maybe at least 40% of the time the biceps is torn as well. So if many of you are treating like my patients, you'll see where rotator cuff, if you see one of my patients with a rotator cuff repair and did not have a biceps tenodesis, that's odd. Because usually you get in there, and if it's a chronic supraspinatus tear, that biceps is going to be not happy looking. It may be torn, it may be eroded, it may be extremely tenosynovitic. Something's not right with it. And those things, biceps are wicked pain generators. And don't forget about treating frozen shoulder. Always remember that motion sets the stage for function and strengthening. So, be sure that shoulders aren't getting stiff, because many of them try to, especially diabetics. So here's the deal. You try to get that acromion flat, you got to get that bursa out, get the rotator cuff, smoothed out, and hopefully with proper therapy, everything sort of unfolds very nicely. And when we get into repairs, it's just like it's sewing cloth together. The anatomic goal is simple: to achieve a high initial fixation strength of the repair, minimize gap formation, maintain mechanical stability until it heals. Sounds simple. The problem is, from an orthopedic perspective, I'm trying to, me and my colleagues, whoever, we're trying to repair tissues that are generally biologically compromised. I'm trying to take a piece of gristle, which is what an end of a tendon feels like, sew it to a bone, and think it's going to heal. It's a complex interface. That's why a lot of rotator cuff tendons don't heal so well. That's one of the problems with rotator cuff surgery. The other problem is, at the end, if the tendon heals, great. What the patient wants is restoring shoulder function and relieving pain according to expectations. How to do that? It's physical therapy. I get it. I've got it for 20 years. And I'm always befuddled at a lot of my colleagues who underutilize physical therapy, especially for rotator cuff tendon-based problems in the shoulder. And essentially, all shoulder problems are rotator cuff tendon-based. Because restoring motion and restoring strength, I mean, I can have a tendon that maybe didn't heal all the way, or it's still weak, or the shoulder has some fatty degeneration. I mean, there's anatomic limits. There's been technical limits of what I can achieve, or in the end, my surgical experience is a little bit dissatisfying. It's not as good as I want it to be. But many times with physical therapy, they look gorgeous. 4-inch of motion, good strength, the patient's happy with it. Now, if the patient has some residual tear, they're not going to have a fully normal shoulder. But many times, as you get older, their expectations and their needs aren't as demanding. And fortunately, the predominant recreational pastime and sport in this region is golf, and golf is very nice to the shoulder. A lot of shoulders that are really not so great shoulders can play golf pretty well. I mean, if your shoulder function is great, it plays golf better. But what's challenging? Tennis. Tennis is tough. I get someone, generally, if I get someone who's had no treatment and they want to play tennis, I say, how committed are you to getting back to play tennis with that shoulder? Would you be willing at some point to moderate that activity? If they say, no, tennis is important to me, I want it. I mean, you need as close to an anatomically normal shoulder as humanly possible to play tennis vigorously and well and durably, which means I'll get MRIs early. And many times I'm offering them rotator cuff repair surgery without even trying a non-operative treatment regimen because I know they're not going to play tennis. Playing tennis with a cuff tear, I mean, then there's some examples. But if they are, they've modified. And generally, the patients who play tennis their whole lives and have such wonderful stroke mechanics can do things. I mean, I saw a guy the other day who's got a cuff tear arthropathy who plays tennis every day for 2 hours. I mean, his arm goes up to here, which is kind of amazing, and he plays. He doesn't have too much pain, and I don't, but these people are the exception. They're not the rule. Generally, someone who's got a cuff tear, tennis is going to be challenging. Now, so would swimming, but not, it's not as common that people are going to be putting their head in the water and swimming freestyle, at length. Repairing the tendon is repairing two pieces of cloth together. You can do it open, you can do it arthroscopic, but also involves removing bone spurs and cleaning things out. Here's an example of the supraspinatus, and basically you take the tendon. Now, generally this tears off the bone. But the other thing is, rotator cuff tendon tears don't tear within the tendon; they tear off the bone. Who knows why that is, but that's the way it is. Just like, say, so Achilles tendon, when they rupture, they don't really rupture off the heel, off the calcaneus. They rupture around 2 to 5 centimeters above. So there's two pieces of soft tissue to put together, Achilles. Patella tendon, they can avulse one way or the other. Rotator cuff, they always come off the bone. So the weak link in the shoulder is the tendon-bone interface, which is what you're trying to restore with surgery, which is why it can be tough. How you do it, you can sew it to the bone. There's anchors that we can use. There's all sorts of things. And sometimes it's not a matter of how you do it. It's a matter that you get an anatomic repair that is secure and seems solid enough to withstand physical therapy. Because a lot of times, these tendons really going to take about 3 months for them to heal reasonably well. I'm going to back that up. So lastly, one of the big things that has changed my practice in rotator cuff is, again, I get it, the importance of physical therapy. I understand treating the shoulder like a piston engine in a car. Remove spurs, get things smooth. The notion of how to repair tendons, that's surgery, it's technique, that's experience. And after a while, I'm not repairing tendons any better than I was 4 years ago. At some point, repair is repair. You can change sutures and all that, but repair is a repair. It's getting it to heal. So the great remaining frontier of orthopedics is improving the biology. So for fractures, it's aspirating the pelvis for stem cells. And you can inject them on fractures or put them in a collagen matrix, and it works phenomenally well. I've experienced that with clavicle fractures that don't heal. But, it works phenomenally well. But stem cells, which when you a bony marrow aspirate, doesn't help tendons heal. It helps bones heal. The proteins that help tendons heal live on our platelets. Now, there's a bunch of them. There's half a dozen of them, but they live on our platelets. So there's these techniques of platelet-rich plasma, PRP. I'm sure you've heard about it. A lot of companies do it, and it's getting a lot of hype. Well, there's a lot of things in orthopedics that historically have got a lot of hype that fizzle. And I don't need to get into all those things right now. This is not one of them, in my estimation. This is real. You basically take the patient's healing capacity, concentrate 1,000-fold, put it on an area that is biologically disadvantageous, which means at some point there's a limit to how good I can repair it. There's a limit to how well you can rehab it. The help that we need to get patients happy and to reach their satisfaction is that the help we need, biology. That's the help we need. And all of a sudden, if we can manipulate biology, all of a sudden, so I'm actually preparing. I just this past about 3 months ago, I ventured at I did a rotator cuff repair in a 79-year-old. Now, of course, he looks like he's 60, but still he's 79. And the MRI said he had a big tendon tear, some atrophy, no fatty generation. It was one of my Pinehurst patients. Wants to be active. Exercises. Would put us all to shame every single day of the week, and he's doing great. 5 years ago, I'm not sure I would have I wouldn't have put the patient through it. Put a 79-year-old patient through a reconstructive shoulder procedure, and 6 months later have the thing not healed. My God, and it's not just a waste of money and time. I mean, that means the surgery. There's always risk to surgery. So where's the benefit? So this is really helping, and there's a lot of companies that use it. This is one. This is what it looks like. Basically, you get off the red cells and this little gold serum. It's pretty amazing stuff. There's no historically we would use meshes and grafts and things like that, and that doesn't work so good. And this stuff works well. 20 cc's in the patient's blood, and you see now orthopedists, which is sort of the nature of our beast, apply to everything. My God, we're injecting hamstring tears and this, that, and tennis elbow, and at some point, the dust will settle. But so many degenerative things in the body occur because the tendon doesn't have the capacity for self-repair as it had when they were 25. So if you could magically make the tendon behave like a 25-year-old tendon, all this repetitive stress wouldn't result in a tennis elbow, wouldn't result in some tendon degeneration or tearing. The tendon just sees the stress, deals with it, remodels, and keeps up with the stress. So that's what biology has done. So again, my last statement, and I'll turn this over to Paul for more of a rehab-intensive discussion. Then later we can talk about questions as much as you want. That the structural reattachment does not guarantee success. So this is not neurosurgery. It's not. Neurosurgeons are valuable and necessary, but they're technicians largely. Meaning, they have a patient that has neck pain, and the neck pain, they have a herniated disc, and they have X, Y, and Z pathology. They will address the pathology, do an ACDF or a cervical fusion, whatever they're going to do, and then afterward, if that neck still hurts, they just turn them over to somebody else. That's the nature of neurosurgery. Orthopedics is a little bit more clinical. If I've repaired their cuff and they still hurt, I got to figure out why they hurt. And so the tendon, the tendon must heal, but more importantly, the physical therapy must be complete. And I think that sort of is a useful segue into Paul's talking about PT, and then afterwards we can entertain and engage any discussion you want.